This meeting is now being recorded.
Okay, good morning everyone and good evening Frances. Welcome to all participants in today's webinar in which Frances will share an overview and insight from her recent visit to New Zealand. I understand we have participants from Australia as well, so great to be sharing our learnings with our Trans-Tasman partners. My name is Carmela Patania, Portfolio Manager here at the Commission with the oversight role for the program. And my co-host today is Sandy Blake, Clinical Lead for the Reducing Harm from Falls National Program, which many of you will know. A few words on protocols. All participants, I understand, have been muted to the extent that we can by the organisers. So if you are having any technical problems, please message using the chat function on your screen. We strongly encourage questions, and there is no wrong question here. We want this to be chatty, collegial and informative. So questions for Frances can be raised via the chat function, which can be seen by everyone, or you may wish to use the Q&A function as well, the button on the control panel. Frances will begin her presentation shortly and will then answer some of the questions you have raised. The remaining questions will be recorded and answers collated by our program team. The webinar is being recorded and will be available on our website by the end of the week. So I'm going to hand over to Frances. Welcome, Frances. Lovely to have you with us, and it's over to you.
Thank you very much. Lovely to be speaking to you, though of course it was much nicer to actually be there, what seems longer than a month or so ago. What I'm going to do is just roughly structure this by the areas I talked about when I was over, but I'm going to talk far more about what I learned than when I came over in terms of the original UK perspective. So, one of the things that was very obvious wherever I went was in terms of being very attached to the evidence base. Both our countries have a lot in common. You have your 10 topics. We have relatively recent new NICE guidance. But they're very similar, mainly because they're both based very much on the literature and the clinical pulling together of research evidence and what will practically work. So that is a brilliant foundation, and it's something to be genuinely proud of. Not every country in the world can say that it's setting the right messages on doing evidence-based falls prevention in all their care settings. So it's something you might be taking for granted, but you should in fact be giving yourself great credit for. I think the other thing that I was really impressed with as I travelled around your country was falls prevention is very much a multidisciplinary business, and yet nearly everywhere I went, you had not only nurses and therapists in the room, but doctors and pharmacists. I think you, just like us, do have to work a little bit harder to get all types of medics with the same interest in falls prevention that you see in your medics, your geriatricians. And I met some brilliant pharmacy staff who have such an important role to play in falls prevention, but they did feel fewer in numbers. So you do need to, I think, nurture and cherish your doctors who are not geriatricians and your pharmacists who have an interest in falls, and just like us, try to make their numbers grow. I think there's somewhere else where we're also at similar places in the same journey. I talked quite a lot in more detail on the sessions, but the evidence base really doesn't recommend counting risk factors. That the sense of taking risk factors, trying to add them up and trying to predict which patients are most likely to fall really isn't supported by the evidence anymore, partly because it's just not accurate, but partly because it distracts from the main point, which is actually picking out risk factors that you can do something about and changing those. So, risk assessment rules in the sense of having a conversation with your patient going through a checklist, working out what factors you can change. But risk prediction scores, risk tools, as we used to use them, it is a challenge, but their use does need to be something you depend on less. We've had this journey whereby we can say there's been quite a reduction in hospitals using falls risk scores, but it's still a significant minority that do, and it is a challenge when that's what you've got to consider. So, it's a really important thing is not the initial risk factor, worrying whether your patient's at risk of falls, but just accepting if they're older, they're in hospital, if they're in a care home, they will be at risk of falls. The key plank that I talked about for most of the time was multifactorial assessment and intervention. And again, we're trying to do very similar things in your assess and act and RNICE guidance. And one of the factors I probably particularly emphasised was the strong evidence that medication is a very significant risk factor in hospital falls and also in care home falls, and that some of the most successful interventions for reducing falls actually have pretty well solely or as part of wider interventions focused on reducing culprit medication, particularly sedative medication. I had some really interesting conversations while I was passing around your country, or really I almost thought I was eavesdropping on your conversations, because you have a very good system I heard about, particularly for residents in care homes, whereby their GPs have to review all their medication every 3 months. So I would have half the room telling me, we do this really well, Frances, don't worry, our GPs always review the medication. Then the other half of the room would pipe up and say, yeah, but they don't really review it, do they? They go through the list and they prescribe exactly the same all over again. Now, I'm not sure quite which half of your room is right. I suspect there's a little bit of truth in both halves. But I think one of the things where you have a brilliant opportunity is this inbuilt quarterly review of medication for older people who are receiving care. And if that became a genuine, thoughtful, courageous review that was ready to try stopping medication that may be doing more harm than good as someone ages, I think that might be an even more promising part of your falls prevention strategies. I talked about delirium, and that again is somewhere, an area where there's certainly increasing awareness in your hospitals and ours, but a sense that delirium doesn't have the profile it should have, is not always recognised and is not always then addressed with the seriousness it should be. And effectively, anything that reduces delirium will prevent falls, and most of the things you do to prevent falls will have a good effect on preventing delirium. And I have to just add, I found a really clever, so basic, it's a study that was published last week, which said that they had a really good strategy for halving delirium in intensive care units. I know probably falls aren't a risk in intensive care units to any great extent. All they did was change the lighting and get the nurses to stop talking at night, and that affected reductions in delirium. So, one of the messages I left with you is perhaps just a sort of psychological fix for how you do your falls prevention as a care home, as a hospital, as an outpatient service. Maybe thinking that perhaps what you ought to do is just phrase your interventions for your typical faller, especially your typical repeat faller, who will almost certainly be someone with perhaps a dementia and a delirium on top of that. Yeah, and it may be the cognitively intact patients who can fully participate in a plan for their care who would be the exception. Another challenge where I was sharing our dirty laundry really was we are not good in the UK at keeping mobility going while people are in hospital. We're especially not good at providing even a basic access to walking frame service for new patients at weekends. That's what the first pie shows. Yeah, and a recent study suggesting that even mobile older hospital patients take an average of no more than 300 steps a day, which is a tiny, tiny amount to the bed, to the toilet and back again, a very few times a day. And I talked a little bit about equipment like low beds, alarms, hourly rounding, all of which can be a great force for good, but all of which also carry a risk that they can be misused to stop our patients mobilising further. So, you know, the challenge we have, and I suspect to some extent the challenge you have too, is that we really do need to take early and frequent mobilisation, especially of medical patients, people in care homes, as seriously as we take these days the very systematic, scheduled mobilisation of surgery and trauma patients. And we can't get everyone to work at weekends, but we can try and get better systems so we have more of a 7-day service through remobilisation. I talked about bed rails, and, you know, again, I think there's a great deal of commonality in thinking and practice. Everyone I spoke to seemed very thoughtful of their patients' individual needs and working out what was best for them. I think you, like us, sometimes have difficulties in the care home inspections tend to be somewhat black and white. You, like us, you have challenges if equipment is changing, and the days when adding a bed rail in a hospital was a positive decision are becoming less because we have profiling beds where bed rails are available to be raised as the norm. But I would strongly encourage you, not just in your practice, but as much as you can in your regulation and inspection, to enshrine person-centred rules for bed rail use. So it isn't never bed rails or always bed rails. It's a genuine consideration of what's right for the person. I think one of the things I spoke about that people had some real interest in was making specialing special, seeing it as if there was one-to-one observation or if there was special observation whereby 3 or 4 patients were being kept together in a zone, that it really had to be respected as a skilled and a challenging task where people needed proper support and proper materials to help do the task well. Like us, you have a variety of environments that you're giving care in, from the modern, which is sometimes better but not always, to older buildings. Yeah, and aspects of flooring, lighting, furniture and fittings are incredibly important for making a safer environment for all your patients. I think you enjoyed some of my black gallery of some of our worst toilets and other settings, but I would challenge you to collect your own photographs like these and use them as a positive force to try and get improvements to your environments. And I did suggest in the meantime that occupational therapists, physiotherapists can do brilliant suggestions for adaptations to people's own home, and sometimes we don't make enough use of them in the hospital and care home setting. What happens after a fall is obviously important too, and I'll talk a bit about falls after care, just what can go, what needs to be detected immediately after a fall. I understand you've got your 10 topics topic on care after a fall has just been issued, which is a brilliant thing, and I would strongly recommend reading, because I wouldn't want you to have tragic cases like the gentleman in the photo on my slide, where we really got everything wrong we possibly could get wrong after he'd fallen and had a fracture and a brain injury. It took us far, far too long to properly detect and treat his injuries. You know, and to separate out those three key tasks really, that we must at least find and treat injuries, then plan to prevent another fall, and then to learn from this fall to stop other patients falling in future. This is the sort of headlines of the guidance that we produced after an inpatient fall, all of which I can see are covered in your new topic for this. Yeah, and it is worth remembering that for some of these patients, it can be quite a long time after the fall that serious injuries become apparent. You know, it's not just that things can be missed for a few hours, but it's even possible for it to be missed for a few days. I talked a lot about how proud we were of our fall-safe leads, who were ward-level specialists who had about 8 days training over 18 months, that genuinely became confident, skilled, you know, had highly specialist skills in falls prevention that their colleagues valued, but were still on their wards every day, able to develop and share their learning. And I certainly know that was something some of you senior leaders were interested in terms of potentially short courses to build up real local experts in inpatient or care home falls prevention. You have a wonderful opportunity in that fracture liaison, I understand, is becoming compulsory as a service for your district health boards. You know, and at least acting after the first fall fracture, you know, the early wrist fracture to prevent the later fall and hip fracture, you know, is something where there's potentially a massive gain in population health and avoidance of harm. I often try to emphasise after I was speaking that, you know, between everyone on this call, just like everyone in the room, between you, I suspect you will have saved 200 lives or so. They're just not as visible as when someone saves 200 people at once in an aircraft. Yeah, but there will be people, because of your efforts, who live to be 80, 90, or even 100. And the vast majority of your patients, you know, not only have their falls prevented, but feel grateful, reassured, protected by the steps you take to try and protect them. And when it came to making falls exciting and celebrating, I did see a beautiful example in this video being developed in one of your areas. So I think you have an immense amount to build on. I also sensed an immense amount of enthusiasm for doing even more. So I just preached a little bit of the lessons from FallSafe, is that actually sometimes you have to make hay slowly. You're doing just 1 or 2 changes every couple of months, but really making sure they're understood and embedded felt like a really good way to go. And there are 100 things we should do better for falls prevention, but we'll probably do them better if we pick just a few, the most important ones, and do those really well. I have to finish with some thank yous for the brilliant team who organised my visit and made every day of it a joy. Especially Sandy, who was my constant expert advisor and companion. And I was also very grateful for the chances to meet your senior leaders and your chief nurse. For those who thought I thought it rained all the time in New Zealand, just to reassure you that after I finished my visit, I had 3 days leisure, and here was a blue sky on one of them in a beautiful island in Auckland Bay. And, you know, I was so grateful to have been invited. It was a privilege and an honour, and very happy to answer any questions.
All right, we're back at the home base here. Thank you very much, Frances. We have a team of us sitting here in Wellington, so thank yous as well. I've got Sandy Blake here, Julian Hope, who's our program manager, and Shelley Jones, who's been our wonderful program advisor and responsible for some of that creative and innovative energy that's going into our resource development. Frances, we've got a couple of questions. One of them that has come through has been a comment around watches. Obviously, some hospitals in New Zealand are using them very successfully and finding that it is improving the falls prevalence and the harm from falls. We know the literature doesn't always, the most recent literature doesn't always support that. Do you have a comment for us on that?
Watchers, as we've called specialing, people sitting one-to-one with people.
Yes, correct.
Yeah. I mean, the literature isn't very good. You know, it's not that there's been good studies that say it doesn't work. There's just been really tiny studies that say we don't know. I think in terms of doing one-to-one watching or doing group watching, it's a very pragmatic solution. You know, it's just the balance of resources issue and the fact that it can be very effective for one person. But to be honest, I think it's a rationing issue. You know, it is that sense of, you know, we certainly have hospitals who are probably spending millions a year in a large hospital with one-to-one observation, which is doing a great deal of good, I'm sure, for a small number of patients. But you sometimes think if we could sit down again and start with that money and say, what would be the best way of spending it to do the most good for these group of patients? Would we absolutely spend it all in that way? Would we perhaps have, you know, zone, cohort observation? You know, would we perhaps with more expert geriatrician, psychogeriatrician, pharmacist input be able to reduce the delirium, the distress sooner and perhaps not need to one-to-one them? But, you know, I don't think there's anything, it really is a common sense, clinical, pragmatic, you know, of the resources you've got, you know, what can you do best for your most vulnerable and your other patients.
Thank you, Frances, for that.
Hello, Frances. It's Sandy here. Lovely to hear your voice. I have a question for you. There's a lot of trendy ways of putting bundles together, and I'm not being disrespectful of that. But the question that's come to me is, if you view the patient as an individual person with individual falls risks, how do you match that to the fact that some places might want to have, you know, 4 or 5 things that are a bundle of cares? Taking away from the fact that, you know, there are essential cares that all of our patients should have in any place or our residents, regardless of their risk of anything, but I'm talking more specifically around falls.
Yeah, lovely to speak to you, Sandy. I missed you, and great question as always. I mean, I have to say, I think what we did in Fall Safe, which sort of had care bundles, was we cheated. Because it was funded by a quality improvement organisation that really liked the idea of bundles, and you can kind of see why people like it, because keeping it simple and saying do the same thing for everybody, you know, is easier to implement. You know, you don't have to think about it quite so hard. It's easier to measure. What we honestly had in Fall Safe was a bundle of assessments, but the interventions then were tailored to what you found on the assessment and what the patient was willing to do. You know, I think that's kind of the closest compromise you can get, because if you're trying to do a bundle, you're not going to have a bundle that works for someone who's cognitively intact, having fainting spells, and a bundle that works for someone with dementia, you know, who's not sleeping well, agitated, and unsteady on their feet. You know, they're going to need a different sort of bundle. But I do think there's things in everyday care that you can measure very well as a bundle, just things like having your possessions in reach, your call bell in reach if you can use it. But, multifactorial assessment and intervention, it has to depend what you find in the assessment, what you do in the intervention, really.
Okay,
thank you for that, Frances.
Great, and it's fantastic. I see a few questions rolling in now. We have a couple here that are focused on bed rails, Frances, from Sue Ellen and I think Cherie. And I'll just read you one of them. There's quite a few questions coming through now, if I can just work out the technology here. Here we are. Okay, so can Frances talk a little more about the use of bed rails, where you have a person who falls frequently from bed, the balance between the use of restraint and reducing harm from falls?
Yeah, this is one where probably just this WebEx isn't going to be enough time, but there's certainly more reading you'll find that people have kindly linked together in some of the materials on the website. We have restraint definitions that are very much based on what the intent of the patient themselves is. So in UK, a bed rail isn't a restraint, but stopping someone from doing what they want to do is a restraint. So if we're using a bed rail on a patient who's hoist dependent, or a bed rail on a patient who is perfectly happy and wants to have a bed rail raised, that isn't restraint. Using a bed rail to stop someone getting out of bed who wants to get out of bed would be restraint. And I have to say, I find that incredibly helpful compared with saying, this bit of equipment is a restraint, whether the person it's used on is unconscious or conscious or willing or not willing to get out of bed. Obviously you have to live with different legislation, but I think that ethical thinking is still worth having alongside it. Just in practical terms, and from the research literature, obviously if you've got the kind of person who is confused and is going to climb over a bed rail, absolutely no sense in having it. Whatever the law says, it's only going to do more harm than good. But equally, saying you never use bed rails because they're restraint, and you have someone who, say, is stroke dependent, slopes to one side, will fall out of bed, you certainly could do more harm than good. And the research literature suggests the risk of falls increases if you're actually evangelical in either direction. So routine bed rail use certainly increases falls, but actually bed rail elimination, especially for frail patients who are not really mobile on their own, have visual problems, looks like it actually increases falls too. So I'd say it's very much one wherever possible, talk to your patients, see what they think, see what they feel about it, and as we run the rules on this, I'll just flick back to the side. It's the issue of not combining bed rails in people who are mobile and confused. Do a little graph here. So if someone was unconscious, why would you not want to use bed rails? If they were orientated and alert, and very immobile, it may be appropriate and you can ask them anyway. And if they're drowsy and very immobile, may be appropriate, but certainly not a good idea if they're fully mobile, and certainly not a good idea if they're fully mobile and very confused. But I think just, think of it as slightly grey, not quite black and white, and, see if you can read some material that I've written which will pull out a bit of the evidence from both extremes.
Okay, thank you, Frances. That's wonderful. Frances, we're changing sort of direction a wee bit, and one of the things that we've been promoting strongly here is the involvement of family and whānau. and that support, and it's a question that's come from Sue Ellen. Can you tell us a little bit about how you promote that over in the UK for us?
Yeah, it's a great question, and I'm sure we don't know it enough, and there's more that we can learn from you. One of the things that's fairly common, but I think we're getting slightly better at, was falls leaflets used to explain what patients could do to help prevent falls, which is great to hand out in hospitals, and I'm sure some find it useful, and sort of had relatives as an afterthought. We've certainly got a lot more hospitals that have two leaflets now, one for the patient and one for the relatives. And given how frail and sick most of our hospital patients are, there's probably about 5 or 6 times as many times relatives can help as, the patients can help themselves. Something we're only good at in patches is getting relatives more involved when we're doing elective care for people with cognitive problems. So it's not uncommon for people with mild or even quite severe dementia, say, to be having hip or knee operations because, despite the extra risks of surgery, they have perhaps pain or poor mobility. And, sort of actually having a plan of relative care. So what would have ended up being crisis specialing actually means the family plan to stay with them in shifts for 48 hours after the operation. Yeah, I've seen that work very successfully when, people plan ahead and sort of say, because she's going into hospital electively, because, she is normally slightly confused, we're really going to need your help to keep her safe. But I'm sure there's much more we could do much better.
All right. Thank you very much, Frances. We have another one, I think, from Sandy here.
Hi, Frances. My question is just for you, maybe asking you if you could just emphasise that when you talk about not using predictive scores for risk assessment, that you're not really saying you shouldn't risk assess a patient. And it's just clarifying that, because if I'm interpreting it right, you're saying, by the time when you add up scores and you get a certain number that says high, well, a person who has a high risk of falls will have completely different factors, and the same strategies or the same actions will not work. I just thought, just so that people on the line are not confused, that they shouldn't use risk assessment skills.
Yeah, thank you, Sandy. I'm rescuing me again. The problem is we use the word risk assessment to mean two really different things. So what I'm arguing against is risk scoring. Going through boxes that give you numbers, you add up the numbers and you say, hey, somebody's at risk of falls. We're just saying that step isn't necessary, especially if they're over 65 or 55 for more vulnerable groups, and they're in a care home or a hospital. Just assume you've already done that number crunching. It's come up with a high number, they're at risk of falls, and get on with looking at the individual factors, whether that is their eyesight or their continence, or their hearing or their mobility, or the fact that they're poorly nourished, their bone health is poor, they're on toxic medication. So it's not counting the risk factors, it's actually looking at them one by one and working out what you can do about them. And that is falls risk factor assessment, but it isn't falls risk scoring. So we're a little bit two nations divided by a common language there.
On to that. Yes, thank you, Frances. Shelley, I think, has something she'd like to say and a question as well to follow.
Yes. Hello, Frances. Shelley Jones here. What you said about risk assessment is lovely, and I can't help listening to you and thinking that this is really an argument for the health professional with the patient to be using clinical judgment and critical thinking. One of the things that Sandy has said very often is look at the person, listen to what they're saying, look at how they're walking. What can you tell from that? So would you like to make any comments about encouraging health professionals to trust their assessment of how a person looks?
Yeah, no, that's a wonderful question, isn't it? And I think, we have to learn to trust ourselves because others trust us, and a lot of that is about management structures and styles, that actually value and reward and encourage professional judgment. My theory is always, if they didn't want you to use your professional judgment, you wouldn't need to be a profession. And I think the easiest way around this I can think of is, I was adding list of sins, I think, the more I talked about, things that go wrong in falls, you're actually saying, have you had a fall? And the patient says yes, and that's what you write down, and you don't go any further. That would be a terrible gap in professional judgment, because the interesting bit comes when you say, oh dear, sorry to hear that, what happened? How did it happen? So, really important to make it a trusting conversation rather than, a formal assessment in many ways, though it really helps to have guides and formats that remind you what you might want to ask about. But professional judgment rules, I do believe.
Okay, thank you, Frances. A few more questions, again, quite diverse. We're now going to Denise, who has asked a question about how do pharmacists in the UK communicate falls risks with their teams?
Yeah, well, that's a really interesting question. I mean, to some extent, we don't worry too much about them knowing whether the patient's at falls risk. It's more about them being able to help the whole team with there's medication here that may make them at falls risk even if you didn't realise it. So the main role of pharmacists in falls prevention and the way they work in wards and care homes, I would say is firstly through their expert knowledge, helping the prescribing doctors realise and remember which medications do increase falls risk. And I would say also an aspect of giving doctors confidence to reduce or discontinue those medications. Because it's always easiest to leave things be unless you've got a reason to change something. And there's some brilliant studies that weren't falls prevention studies, but were just based on care home reviews of medication, in terms of did they really need them, was there any likely benefit, especially to preventative type medications, in people already in their late 80s and 90s, that show, you can get probably a lot better quality of life and often longer life with less polypharmacy. So, it's vastly different having a ward with a visiting pharmacist and a ward without one. And I would say, it's not so much that you have a pharmacist that talks about falls risk, but a pharmacist who gets very good at making everyone think about the risks and benefits of all medications, and that for a lot of frail and multi-pathology patients, the risks tend to outweigh the benefits, and falls are a big part of that risk, but by no means the exclusive one.
Okay.
I would probably spend my millions of specialing money on several pharmacists if I really, really had to put my money where my beliefs are.
That's interesting. Thank you, Frances. Did you want to add something?
Yeah, Frances, it's interesting because the little Wanganui, we have a shortage of pharmacists and gosh, we really feel it. So if you've got any spare ones over there, can you send them our way?
Well, if the weather carries on like this, I think you should find it quite easy to attract a few over for years to come. And
Frances, thank you. There are a couple coming through now, threading along visual aids and signalling in terms of what people are using either above the board or in the wards around risk of falling. But there are two threads coming through here. One is risk of falling, but the other is really how one mobilises safely. And I think they are two quite different things. Now, the Commission has promoted a package which we call the signalling system, and it really is around safe mobilising. So I think there is importance in understanding those two quite clear distinctions, but there are a couple of questions where people have said, what are some of your comments around the use of visual aids for those two things? Would you like to make any comment on it, Frances, for us?
I must say I'm a great fan of visually signalling what help someone needs, and you have some brilliant examples, some of the best designed I've ever seen. I do have my doubts about putting up a sign to say someone's at risk of falls as opposed to here is someone who shouldn't be walking without supervision, because again it's what does it mean. Now if you have a sign that means to people this means I mustn't let them walk alone, that's fine, but not everyone at risk of falls shouldn't be allowed to walk alone. You know, if the sign means courters know they mustn't take someone off the ward without a nurse escort, well, yes, it holds the use. But yeah, I would be much more of a fan of something that helps you know exactly what help your patient needs with their mobility and helps you know to jump in and intervene if they're on their own and they shouldn't be, than just a symbol that says falls risk, which people will probably take to mean they must not walk alone, but isn't necessarily the case for that individual.
It's lovely. And Frances, I suppose I'll just wrap that up and say that the signalling system that the central region have adopted across the region, and we have had some others now express an interest in that, does exactly that, and we have been very deliberate around how we've packaged that up, and it is around safe mobilising and what help is needed to do that. So that's very good. So thank you for that comment. There's another comment here.
There's a sort of half question in it about stickers and charts. I mean, just to pick up that one, I would say I'm a great fan of stickers for communicating you want someone to do something. So we do have quite a few hospitals who use a sticker by which they will put a note in physio notes for a particular request in relation to falls, or medical notes highlighting which medications they'd like reviewed, or pharmacists who will put little stickers against all the medications with an increased risk of falls, and then stick another sticker in the next blank page of the medical notes asking them to sign that they've considered whether to stop them or not. You know, so over and above the signalling at the patient level, you know, it's an easy, clear way to communicate sometimes is sticking a sticker to ask them to do something in another part of medical notes.
Okay, that's great. Frances, you touched earlier on the fracture liaison service, and that is a clear directive for all DHBs to be implementing that. And in tandem with that, obviously, is a hip fracture registry, and we know there's been a lot of advancement and big gains made in the UK and other countries on that. We have a question around, can you comment a little bit more about what the benefits that you see from this type of service, and it's specifically around fracture liaison?
Yeah. I mean, hopefully, though it's fracture liaison that's mandated, you know, it will end up being falls and fracture liaison. So, you know, it'll be looking at, okay, they fractured once, what can you do both about to improve their bone health and stop them falling again? From our national audits, we know it makes a massive difference. Not all our areas have fracture liaison. About half, slightly more than half do. In the areas that have fracture liaison, we get more than twice the number of people receiving proper evidence-based secondary falls prevention, evidence-based bone health treatment. So it makes a massive difference, and that's often just at the level of one fracture liaison post for what will be, a large 600, 700 bedded hospital with, an equivalent A&E department seeing very significant numbers a year. So it's a wonderful opportunity, and it just seems to get round the human reality that A&E departments have to be good at patching people together, but it's very hard for them to arrange all the future care someone needs, whereas fracture liaison, actively case finds, doesn't just send people a letter in the post and hope they respond, but genuinely tries to get people into the pathways that are there that they might miss out on otherwise.
Frances, that's great. I mean, we see it as a great opportunity. It says fracture liaison service, but the ultimate word is also liaison, and we'd like to see it as falls prevention embedded in there in terms of referral pathways, stopping more serious fractures and fractured hips occurring, so you're intersecting early and getting that pathway for individuals.
Absolutely, and it would be a wonderful world if we prevented the first fracture, but the reality is there's still an awful lot can be done to prevent that wrist fracture becoming a hip fracture. So it's a really important opportunity to seize.
I think we have another one here. Thank you, guys. We really appreciate your participation and some of the questions coming through. It's wonderful. Sandy, I think, had another thread for us.
Frances, when we look at, and I have to kind of use a nursing lens here because I couldn't be a director of the nursing without doing that. But when I travel the country here and look at all the paperwork our nurses do around risk assessments of all sorts of things, they have a booklet of assessments which takes all their time to do those assessments, a lot of their time doing those assessments. And then when I skim across a number of those assessments, they ask the same question, just maybe with a different score or a different wording. For example, you ask about mobility in pressure ulcers, you talk about it in falls, you talk about it across a number of things around cognitive assessment. So my thinking is when you look at the idea of a geriatric syndrome that we kind of need one risk assessment, which includes the questions that are pertinent to falls in that for our people. So it's looking at our frail people, it's looking at a kind of a person-centric assessment rather than a different type of assessment. And I'd just like your thoughts on that. Thank you.
I totally agree, though we're equally guilty, and it feels every time I look at local hospital documentation, someone's added another page of boxes to it. And I think the great hope for being able to go to that approach is, if you have a predictive score, if you have numbers that tell you someone's at falls, and you have numbers that tell you someone needs a pressure-relieving mattress, and you have numbers that tell you someone's at nutritional risk, because of their sort of statistical predictive values, you have to do them all separately. Now we are getting to the point where people are understanding, not just for falls, but for these other things, you probably don't need to use them, which older person with a week's stay with an acute illness is not at nutritional risk or pressure ulcer risk, let alone not at falls risk. So if you can take away the scores, I think then, that genuine format whereby, it works for all of them, doesn't it? And I do think frailty is the umbrella under which we might be able to make that change of practice, that a frailty assessment will cover pressure relief needs, mobility needs, falls prevention needs, nutritional needs, but with a lot less repetition. But it will have to be an assessment in words for that person rather than an assessment in numbers and tick boxes.
That's excellent. Thank you, Frances. We're sort of heading towards the end of our hour. I mean, it's been fabulous. Frances, I don't know whether you want to add anything else that may have come to mind, or do you think we could head towards wrapping this up?
I think, you know, there was nothing else specific I wanted to add. The only thing I thought where I didn't answer a question was hip fracture database has been wonderful for us too. And some of that is related to financial rewards for better care, but a lot of it are related because, you know, nurses, therapists, I'm not sure we're always all that competitive. We're naturally quite collaborative. But orthopaedic surgeons, hell, are they competitive? So I look forward to you having competition for your top scorers for all sorts of good outcomes for your hip fracture patients once you've got a database where they can compete on quality. But no, you know, other than that, nothing to add except, you know, I'm so impressed. You've got such a lot to build on. I look forward to coming back when Wanganui has the first frailty assessment that others can copy. That would be great to see.
That's fabulous. Frances, I suppose in wrapping up, you know, we know we've had a strong national focus on falls for 3 years and we're heading into our final year. We know that there will always be a residual role on falls. We know it's a long game and we're all aware of that, and we're all tasked with, you know, continually having to measure and report and what change and improvements have we made. So we're all fighting that game, and I remember you clearly articulating it's a long game and you've got to be in for the long haul. What would be some of your final words of advice to us as a national program team about what are the key things that we should be focusing on, and for everyone really, for everyone's view of what they're doing locally and regionally in terms of what we should be focusing on going forward in our last year?
Oh, I think investing in some of the education, perhaps, you know, moving people on from enthusiasm and everything they could teach themselves to, you know, not intensive courses, but settings where, you know, they're taking that knowledge up to another level and genuinely can start to confidently challenge other disciplines. I think being more aware of what other people offer. I can remember sitting at a table where a lovely care home were trying to work around a very difficult patient, you know, and behaviourally, nursing, therapy-wise, were doing everything they could. But this guy clearly had health problems that would have benefited from a geriatrician. And at the same table was a geriatrician who thought everyone knew. All they had to do was pick up this line and they could have geriatrician visits to care homes. But neither of them knew unless they'd been at that Falls Day. So, you know, I guess carry on doing what you're doing in terms of encouraging people to get together, especially across professional disciplines and care homes, and learn what they can offer each other. And, you know, I think probably the frailty agenda is the right way to go, you know, and that's the way to carry on driving improvement in falls, but, you know, helping it merge with improvement in all the other things that are important for our older people.
Okay, Frances, that's lovely. So, Frances, on that note, I guess my clear message is that it is around the multidisciplinary approach. It is about integration, and it is about our continual focus where we are trying to look at hospitals, aged care and prevention, the population, community-based settings. So we're continuing that drive and national guidance, and I just want to say thank you, a heartfelt thank you to you. I know it's quite late at night, and thank you very much to all those who have participated in New Zealand and in Australia. And I just, Sandy, I'm going to hand over to Sandy shortly for our final few words, but I want to thank Lisa Burns, who's been our technical specialist sitting here with us, because this is all new to us, and I have to say it's gone incredibly well, so thank you to you all, and hopefully we can repeat these in the future.
Thank you.
Thank you very much for listening.
And thank you, Frances, your wisdom. We just thank you so much for that. And we hope that we can keep this partnership going, and And we do hope that you will be able to share some of our New Zealand advances with the rest of the people that you speak to in the world. And just hopefully, and that you have a happy long Queen's birthday weekend, and you enjoy a break. And just thank you for staying up so late. We feel so privileged that you would do that for us. So thank you very much on behalf of us all here.
Thank you very much for having me. Pleasure as always. And yes, my slides everywhere I go now, a list with New Zealand things and photos, I promise.
Okay, we'll sign off for now. Good night and farewell to everyone.
Thank you, everybody. Bye.
Bye now.